welcome to Thinking Green. I'm Rana, and today we're kind of continuing our series on legislation that's being considered in Connecticut and in Washington, D.C. And today's show is about health care and the need to make big changes. The Green Party has been in favor of a single-payer system for at least the last 20 years, and hopefully we're starting to see some movement on that. And to that end, today's guests are from Medicare for All Connecticut. June, Joanna, and Stefan are joining us from that group, and we'll talk a little bit about what's going on now, what the problems are with our current system, and how we could make it better. So welcome all three of you. Thanks for coming.
Thank you.
Thank you for having us.
So I guess I'm going to start out, and you can sort of maybe each of you give your perspective on how you got involved in advocating for universal health care. You can start anywhere you want. We're pretty informal here.
Yes, my name is Stefan Ramdor. I am a member of Medicare for All Connecticut, and the reason that I am involved in this is just the current private health insurance system. It involves a lot of disruption. So, for example, in the last 3.5 years living here in Connecticut, my wife and I we were on seven different private health insurance policies, just because it's tied to employment. And then with myself being self-employed, my wife changing jobs 2 times. There was a lot of disruption, a lot of stress also caused by that. Networks of providers that change, like when you change your insurance. So then you have half of a procedure done, and suddenly your insurance changes. And yes, so all of that would not have to be that way, because we could have a Medicare for All single-payer program that would cover everybody without any co-pays, deductibles, and out-of-pocket costs at all.
Which is something that a lot of the rest of the world already does.
Right.
Okay, Joanna.
Well, I actually don't have a problem right now. I have original Medicare. The 20% is covered by my retirement benefits. But when I look around and I see the mess that we have, I couldn't exactly stand still. And actually, some of my retirement money is going to help my 2 grown children who are both self-employed and therefore have all the problems that most of America has. And it really is horrible. If you're poor enough and you're on Medicaid and you're in the right state, you might be doing all right. But then if you earn a little more money, you could be thrown off Medicaid. Then you have to start all over again with private insurance. Every autumn, when these things change, is another mess. A lot of distress for everybody. They have to start all over again, make sure that they have the insurance that they need, if they can get it. Fill out paperwork all over again. A lot of it is needs-based. So if your income changed, your situation is different. And I got into it because I like cleaning up messes, I guess.
Well, you chose a big one this time.
Yeah.
What about you, Jude?
Well, as a healthcare worker, I see how the sausage is made. And most importantly, throughout my work as a hospital nurse, every time we got some improvement in technology that allowed us to be able to have more freedom of time to spend with the patients and give them real care, we suddenly found that we had more tasks to do, which were not related to patient care. And this was a spiral that just continues. And I couldn't understand it until I realized that the work that we are doing, which is supposed to be caring for people's health, is actually a form of production. And so what we are producing is not health for people, let alone comfort, but it is producing profit for the industry that controls the money. And that is the one who takes from the people, puts most of it in their pocket, and then doles out just enough to keep the system running. And that made me very angry, and that's why I'm here.
Well, and thinking about that, I know that nursing is a field that has a huge attrition rate, and I'm guessing that one of the reasons is that people go into it because they want to care for people, and that isn't what the job ends up entailing.
Not just nursing, doctors too. And I can attest to this from my personal experience. Once this generation of old nurses die out, and we are holding on because we have no other alternative. We still have to make a living. We still have to live, but we're too old to get a new job. But the young nurses who are coming in, they are transferring away from the bedside within 5 years. So that means y'all being taken care of by rookies. All right?
Yeah, and the few nurses left are doing the paperwork, right?
Yeah, but mostly because people won't stay at the bedside for more than 5 years because it's too hard. We're being forced to produce too much, and too little of it is going to the patients. That means that most of the people on the floor are rookies. You can't be a good nurse with just 5 years experience. You can be really great at your schoolwork, but there's a whole other dimension that it takes time. And so, yeah, that's how it's being made.
Wow. So Stefan, I
Yes.
think you're going to be the one to talk about the Medicare for All Connecticut group and how this got started and what your activities have been.
Yes, so Medicare for All Connecticut, we did have already a lot of activities, some of them including, for example, last year in summer we had a town hall event in East Hartford, so that was a big success. We had a panel of experts
It's not showing
answering
up.
questions.
I guess we can show the slide of your, of the logo of the group to start with, I
Sure,
guess.
sure. So
Oh.
this here is
Oh.
the town hall event, and this here is the logo of Medicare for All Connecticut.
How long has the group been in existence, the Medicare for All Connecticut? It seems,
It started, I
Fairly
think,
recent.
after the 16 election. So, but yes, so that, for example, the Medicare for All Town Hall event last summer brought together like a lot of groups co-sponsoring this event. I think more than 30, and also brought out, even if it was a sunny summer Saturday, about 200 people just asking questions to our expert panel here about Medicare for All and all the different aspects of healthcare. Yes, that's something that of course we continue to do, try to do events just for the public to be able to ask their questions and get informed about what a Medicare for All single payer program might look like.
now what other organizations are you partnering with? You said there were a lot of organizations that take part in these presentations. So it isn't just Medicare for All Connecticut, I'm guessing. There are more advocates.
Yes. So there's, for example, a group called Physicians for a National Health Program. They are very involved in the fight for Medicare for All single payer program. Then, of course, we do have also here in Connecticut different chapters of Democratic Socialists of America, DSA. So they are very active, and for that specific event, we had like lots of also unions as co-sponsors, faith groups, other community groups. So
Churches,
yes.
Oh,
Mhm.
yeah?
yes.
I would guess that any kind of group that's dealing with like emergency, rubber meets the road kind of services would have an interest in how our healthcare system is working.
And the way that the healthcare system is set up is a profound failure of love. So that's very much a church concern.
Yes. And then another activity of the group was in September to hand over 17,000 signatures of Connecticut residents in favor of a Medicare for All single payer program to Senator Murphy, encouraging him to sign on the Senate bill S 1804, the Medicare for All Act.
Now, just quickly, has he done it yet?
Not yet, but of course we are delighted to have Senator Blumenthal as a co-sponsor, so we hope Senator
So-
Murphy will join his lead.
Okay, just checking.
Yes.
And I think you have a couple more slides, a couple more things you've done.
Yes, so this year was very recent. At the end of February, there was the rollout of the current bill in the U.S. House. So that's H.R. 1384, the Medicare for All Act of 2019, with more than 106 co-sponsors, I think. So a lot of Democrats in the U.S. House already in favor of Medicare for All legislation, and Medicare for All members were present here in Washington, D.C. I think it was on February 26th for the official bill rollout right in front of the U.S. Capitol.
So it seems as though the idea, at least, is starting to catch on.
Yes, absolutely.
And so, let's see, and I think, are there any other things happening in Connecticut right now or at the Capitol right now related to the bills?
Well, here our Connecticut delegation, for example, regarding the U.S. House side of things, we do have our very first member now, Representative Johanna Hayes of Congressional District 5 here in Connecticut. She is a co-sponsor of the Medicare for All bill in the U.S. House, something which we, as far as I know, did not have before. We never had any U.S. House members from Connecticut be signing on to Medicare for All, so it's exciting. So even here in Connecticut, there is more support for Medicare for All now.
Wow, so it is kind of a growing wave. I guess I want to know kind of what's going on with our current system. What are our problems that we have to solve?
Well, the biggest problem is the insistence of our Congress on keeping private insurance where they are, which is right in the middle of things. They're like the trolls under the bridge. If you want to pass the bridge, you have to pay them first. And I think if you had to pick one problem, that would be it. Because their drive, and in fact their legal obligation, is to make money. That's their job. They are there to make money for their investors, for their private owners in case it's a private ownership. And that's in direct conflict with the job that they're supposedly supporting, which is healthcare. So the way they make more money, they maximize their profits, is by raising what they charge you, raising the rates, and limiting the health care that they give you. That's why there are denials. That's why people have certain medical issues and they think it's going to be covered, and the doctor thinks it's going to be covered, and the insurance company suddenly denies it, because that's how they make their money. And I think that's really the essence of the problem.
And this wasn't always legal. I seem to recall that until about the 1980s, physicians could only work for physicians. You couldn't have an outside owner because it was considered in conflict with the Hippocratic Oath.
Exactly.
And you couldn't make profit. It was Nixon, President
Yeah.
Nixon, who changed that. I think it was the late 70s, 78 or something. And from what I read, it was a friend of his in Kaiser Health that he did a favor for. And so he made profit acceptable within healthcare. Before that, it was not acceptable.
Because a lot of us remember when, even if we didn't necessarily have insurance, that medical bills were relatively affordable.
They were. I remember that.
And now...
Blue Cross and Blue Shield were nonprofit. They were public.
That's right.
Right.
In fact, it was around 1990, I think, that they demutualized.
Yes, I thought it was earlier.
I'm not sure about
Or
that.
late-
It's-
80s, I thought
late-
it was. 80s.
I was covered by them when they demutualized, and they sent me a $900 check. And I bought out, because, previously, the people they were insuring were their shareholders. There wasn't an external set of shareholders that wanted to make money. And I don't remember what year it was, but it was during the time I worked for Head Start, I think in the 90s. And I got this $900 check, and I didn't think much about it. I was pretty, naive at the time. And then after that, our insurance just changed.
Yeah.
The whole system that we were under just changed. So I don't know if there are any other, insurers nowadays that are still mutual companies rather than shareholder owned, but
I don't know.
that was a really bad development that's brought us, I guess, to needing to take the outside insurers out of the picture entirely.
Yes.
Absolutely.
Yeah, very much so.
Well, one of the things, one of the side problems is that with our current system, I mean, not only is it not good health care, but the cost of it just causes so much damage to people's personal and family life. I mean, I remember once reading something about how no one in Europe could understand a TV show like Breaking Bad happening, because like the idea of like being sick and like facing financial ruin to the extent that you had to, become a bad guy in a crack manufacturer was just like totally an absurd concept to any nation that has a decent system.
Yeah, I mean, the
Yeah.
cost, of course, is a huge topic. And for example, we have this here, like an image from a news report last year in Boston. There was, for example, it widely being reported that there was a woman who was injured. She was kind of stuck, I think, between a subway car and the platform, and so bystanders were looking to help. At the same time, she refused to have an ambulance being called for her because she said that that would be $3,000, and with her health insurance, she would not be able to afford that. So, yes, of course, cost is like, I think that's very detrimental to people's health, and that they're seeking the medical attention and the care that they need.
It seems as though every so often we see these graphs of like how many people lose their homes, due to medical debt, and in the United States it's a pretty big number, and then you look at the European countries that have their various kinds of universal health care, and it's like no one.
Yes, and
Yeah.
actually we do also have like information here on that. Like, say there are statistics
Oui.
about that most of the people who have a medical bankruptcy actually did have insurance at the onset of the illness. So even insurance by itself, having it, is not a protection against that. And then at the same time, also, of all the bankruptcies, of all the collection calls, most of them are due to medical expenses. So,
And that's even for people with insurance.
right. And as we just
Yeah.
saw, like, most of the people did have insurance at the onset of whatever issue that in the end caused them to have this situation. So,
Well, thinking about that, I remember reading, I don't know, some little saying that only in the United States does the term pre-existing conditions exist.
Right.
And you were talking about, all the different, insurances you've been on, and each time you change, then you might have a pre-existing condition that wasn't necessarily pre-existing, at a time in the past when you were insured, but by a different company. And, this little saying was, well, in most countries there aren't pre-existing conditions, it's just called your medical history.
Exactly.
right.
Yeah.
I mean, of course, say if you take United Kingdom with the National Health Service, or the public non-profit health insurance in Germany with the signatures funds, or I think all of these programs would, of course, not know anything like pre-existing conditions, because it's out of the world of private insurance. So that's not a term that a public program would use. And why would it, if the
Right.
objective is to just provide everybody with the care they need?
Yeah, probably some business guy, higher up insurance guy, was very proud of that concept.
I'll bet. And that's part of this yearly distress that we have. Every year it can change, even if your job doesn't change. Your employer may change insurance companies for one reason or another. And every autumn it's a whole new trauma. It's absurd.
Now, to what extent has Obamacare helped or not helped the state we're in regarding insurance?
Well, it definitely saved some people's lives, because for a while there was, they evaporated the pre-existing condition problem. So some people who had a very serious condition could then get medical care. So I'm sure it was excellent for them. But in general, it kept the private insurance in the loop, and the overall costs were still outrageous. they put in subsidies, so some people got lower premiums, but that didn't mean that the cost went down. It was just moved to another pot.
It was kind of like when you got that $900 check. No, the $900 check was eliminating pre-existing conditions as a pretext to refuse coverage. That was the payoff. But what they did was they entrenched the private insurance industry more deeply in our health because it became illegal to refuse to insure yourself. And so you either paid the insurance company or you paid the government. And in addition, because health insurance is intrinsically expensive if it's private, because every element of their system is to derive profit from our illness and our suffering and our fear of bankruptcy. So therefore, the cost is high. Therefore, the Obamacare was set up to tax everybody and provide subsidies to those who didn't have income that could support the premiums. So it was basically the government was the hitman, okay, or the muscle for the insurance industry, and it leaned on all of us. And that's Obamacare.
And I think, when we were talking before the show started, you had mentioned about how much overhead there is in terms of filling out the paperwork.
Mm-hmm.
And it's shocking how many jobs there are in this industry that have really nothing to do with healthcare at all.
And no value.
It does have value because it inflates the cost of care, and the inflated cost of care is then a pretext for raising premiums. It's very well thought out.
Well, no value for us.
Oh,
Right.
indeed.
Well, I heard someone say recently, if there is a problem and it seems really an entrenched problem, instead of, if you want to solve it, instead of looking at who's suffering from it, you have to look at who's benefiting
Yep.
from it.
Yeah,
Cui
right.
bono.
Yeah.
And it goes beyond healthcare. I think about related things like, the push to make privatized public education, other kinds of public goods services that have become profit points,
Yeah.
that someone's getting rich off of them.
Yeah.
Yeah, of course, healthcare, the problem, maybe it was alleviated a little bit. So we have, for example, here the uninsured on the slide, the number of uninsured in the United States. Of course, the introduction of Medicare, Medicaid caused a big drop in the uninsured when those programs were instituted, and then we have like a tiny drop. I mean, of course, it is substantial still when the Affordable Care Act came into effect. At the same time, there still are approximately, there are different estimates, but like 35 million or so uninsured in the country. So once again, comparing that to other countries, if we have the United Kingdom with everybody on the National Health Service, or I think Germany, you're having an uninsured rate of about 0.1%. So here having approximately 15% of people uninsured, it's a lot. So it's a huge problem.
So what impact has that had on our health outcomes here? I don't know.
Yes. So we do have, say for example, that the current system does keep the high costs, keep people from seeking care. So these bars show how much how many people, the percentage of people who do not seek care, although they should, just because they have high deductibles. Or like then, I think the most shocking would be just also the amount of people who, according to estimates, die each year because of not being insured at all. And for example, here in Connecticut, as far as I know, the estimate is about 175,000 people are not insured at all. So yeah, of course, it's having a huge human toll.
Wow.
Yeah.
That's actually quite frightening. So,
I've
Now-
cared for some people who died because they didn't have insurance. That made a very deep impression on me.
and I'm guessing well, it's been in the news that there have been some people who were insured who died because their claim was denied.
Or
Yeah.
because they didn't dare to seek care because they had a high deductible and they hoped it would go away, and it didn't.
All those reasons.
Yeah.
Yeah, people delay care, like because of cost or because of not being insured at all.
Yeah, and then they get blamed for delaying the care. For not,
Well, then you have a pre-existing condition, right? Yeah, it's kind of a, so how, I know the cost is much greater in the United States than a single-payer system would have. What kind of scale are we looking at?
Yes, so the United States has the most expensive healthcare system in comparison to all other countries. So I would round it up and say it's about $10,000 per person per year that the United States spends on health insurance, while other countries, say if we have United Kingdom with about 4,000 or Germany with about 5,000, so they spend about half per person per year on health insurance. At the same time, one might argue that they might have better outcomes.
Certainly more across the spectrum of people. I'm sure there are some individuals in the United States who have excellent health care. But you mentioned $10,000 as an average, I think, in the United States for annual cost. And it seems to me when we were doing some research about costs of health care, for Medicaid recipients, not the high-risk nursing home ones, but just the people who qualify for Medicaid because they were low income, I think I had heard that cost of coverage is $3,000 to $4,000 a year. So it's considerably lower than the
Yeah.
private insurance numbers.
Right.
and it would be lower still if there was no private insurance at all, because part of the cost of care is the cost of servicing this predatory, parasitic financial industry. Providers have to hire multiple billing specialists because they have to juggle all the different insurers and all the different plans that the insurers offer and all the different rules that each one has for what you can claim and what you can't claim. So they have more billing specialists than clinical staff. They have more billing specialists than beds, and that's expensive. So if we cut that industry out, we would save a lot of money.
Now, this isn't exactly the same thing, but is closely related. Pharmaceutical prices. Drug pharmaceutical coverage is included to some extent in many insurance policies, but once again, we can't, negotiate drug prices as a big pool in our current system. So do we end up with people, well, I know we end up with people who aren't getting their medications.
People are dying because
Yeah.
they can't get their medications. The manufacture of medicines has changed from a production industry to a financial industry. So medicines can change tier and change price not based on how much it costs to research and produce them, okay, but rather on the change of ownership of the company that's making it. And so, in addition, high pharmaceutical prices, again, are a good pretext for raising premiums. So they have their own shell game between the pharmaceutical companies, the pharmaceutical industry, and the private health insurance industry, that they give each other kickbacks, they use tax dollars to give each other kickbacks, and they are able to keep spiraling their prices up.
And some of these aren't just the new, brand new drugs. It's things that have been on the market for
Right.
like a century.
Yeah,
Yes.
insulin is the one in the
Yeah.
news lately. That's been around forever. It should be costing very little. And all of a sudden, what cost, I don't know, $50 is all of a sudden cost a few $100s for
And they
no
know-
reason other than they would like more profit.
They know people will pay.
Now, there are a couple of bills that you mentioned in the House and the Senate. Senate Bill, 1804, and House 1384. Do you want to talk a little bit about what each of these bills would do? And
Either.
So I had prepared some information about the House bill because that's the one that is currently been most newly introduced into Congress. There is a mirror bill in the Senate also, which is now being gone over with a fine-tooth comb to improve it and bring it up to the standard of the House bill. But the House bill is H.R. 1384. It's called the Medicare for All Act of 2019. It was introduced to Congress on February 27th by Congresswoman Pramila Jayapal, who is a representative of the 7th District in Washington, and also by Deborah Dingell, who is a representative of, I believe it's the 12th District in Michigan, and they had a total of 106 co-sponsors of that bill upon introduction. The salient and important points about it is, first of all, it is a single plan which covers all U.S. residents equally. The enrollment is very simple. You simply, if you're already born, you apply and enroll. You get your Medicare for All card, and you're done. You don't have to re-enroll in subsequent years. You don't have to prove that you are poor enough or rich enough or anything like that. You have your card. Now you are entitled to use the card to go and get care. For people who are not born yet, they are enrolled automatically upon birth, and people who are coming to the United States, once they are part of their procedures for becoming residents is that they receive the Medicare card. So what care is covered? All medically necessary care is covered. I can't be more simple than that. It's, head to toe, soup to nuts, inside to outside. It's women's care, pediatric care, emergency care, acute care, preventive care, long-term care. These are all covered, including, if you want to break it down, some ancillary services which are very important. For example, for people who don't have transportation to their provider or to a hospital or something like that, this card will pay for transportation to get them to care. It's not going to help to have free care if you can't get to the door. The other question that people may often ask is, well, what if I go out of network? Because we know that in most of the plans that we have certain providers who are approved, and they are inside the network, and people are outside the network. You have to pay more, or else you have to pay a very high premium to get a plan that covers everybody. But there's none of that with the Medicare for All Act of 2019. There are no tiers and no networks. Everybody gets full coverage, and they can go to the qualified provider of their choice. So it's no longer the insurer deciding who you can go to for your medical care. It's yourself. The control of our health is put back in our hands, and the relationship is between ourselves and our doctor, and not with somebody standing in between saying, yes, you can, or no, you can't, or no, you can't prescribe this medicine because I think this medicine is better. I don't have a medical degree, I have an accounting degree, but this is what you have to do. Question, well, what do we pay? When you go to the doctor, the care that you receive is free. Okay, there are no cost sharing. That means no co-pays, there's no premiums. You don't have to buy extra insurance to cover all the things that the plan that you bought doesn't cover. There are no deductibles. There are no caps on how much coverage you can cost them before they'll say, okay, we're not going to pay any more for your care. And there's also no balance billing. Balance billing is when the doctor sends them a bill and they say, no, we're only going to pay half of it, and then the doctor sends you the rest of the bill because he needs to keep his lights on. So for most people, the elimination of these extra things that we pay outside of our premiums is equivalent to a $7,000 to $10,000 tax rebate. And we need to keep that in mind because everybody is moaning and groaning, well, we're going to have to raise taxes. Oh my God, they're going to tax us. Well, let's pay attention to where the money's going. Okay? You can pay $10,000 to the insurance industry, or you can pay less than $1,000 to the government, and you're getting the same care. Okay.
Well, I think when we think about budgeting in general, we have to start thinking about what return are we getting on our investment, and not if the number next to the dollar signs looks like a high number or not.
Yeah. Well, it certainly is better care if you're getting full coverage instead of partial coverage. Employers benefit, especially small employers. Right now, the cost of insuring employees is breaking small businesses back. And they may simply, to survive, either not cover their employees, or if they have enough employees that they are legally required to cover them, that then, they will say, well, I'll only hire people for, below the threshold, less than 20 hours a week. So everybody's got part-time jobs. They can't get insurance, and it's a mess. We have to understand that in addition to premiums that employers have to pay, they have to go and shop for plans. They have to administer the plans. They have to keep in compliance with, what insurance they have to offer. All of that extra paperwork on top of the premiums is what it costs employers to insure their employees. Okay, with Medicare for All Act of 2019, HR 1384, all of those costs go away because there is no private insurance. There are no employer-offered plans. It's all being done by the government. So for employers, we're talking about a $10,000 per employee per year reduction in payroll expenses. So we're saving a lot of money.
Well, I think of what a boost it would be to our economy
Yes.
in the global marketplace.
Yeah.
I once went to this union interview when I was running for some local office, and all the union people wanted to know what brand car we drive. They wanted, us to be saying they were all American nameplates. But my story was that I drove a Corolla. It was made in Canada. And the reason a lot of automobile manufacturing moved from, north from Michigan to north of the border was that the cost of providing health care insurance, both the current employees and to retirees, was adding $1,000 to the cost of every car that was produced. So a low-cost, low-end model like a Corolla could not be built in this country.
Yeah.
So it was built by union, workers who got a good wage, but because Canada provided the health insurance, they could do it.
Yep.
So, we can't, we worry about not being able to compete with China or the global South, but actually we can't compete with the rest of the industrialized
That's right.
world either, especially in manufacturing.
I think anytime they say something about, how will we pay for it, even if we don't go into these details, the question is if we're paying twice, if what we do costs twice as much as anybody else, and if a single payer costs less, how can you say we can't afford the one that costs less, we can only afford the one that costs more?
Exactly.
How much sense does that make to anybody?
And even in the worst case scenario, if we weren't actually saving money but just getting universal coverage out of it, we'd even still be better off,
Absolutely.
even if the numbers were the same. But we know that we can save, at least 60% over what we're paying now.
Yeah.
So, yep. Long story short, it's cheaper and better.
Right.
Yeah, and much simpler.
And simpler,
Much
yes.
simpler. The complexity of this should be enough to drive anybody away from it, really.
Yeah, you'd think.
Just, every year it's a new hassle. Every medical issue, it's a new hassle. I know we have people in my family, a couple, they're both full professors at universities. They have what this country would call good private health insurance. Well, they save as many medical issues as they can for when they travel because it's easier and it's cheaper. Even with no insurance there's a lot of stuff that's cheaper. That's crazy.
That is crazy. And I think one issue is, if you're facing a serious illness or accident, the last thing you want to think about is how you're going to pay for it.
Yeah.
You want to be able to focus on, healing, right?
Yeah. Absolutely.
And not wonder whether you're going to end up with a lien on your house at the end of it, or have to, interrupt treatment halfway through so you don't have a lien on your house. It's, really can be pretty stressful, and that
Yeah.
does not help your health journey, I'm sure.
Not at all.
Yeah, what we have makes no sense in any direction.
So, yeah, are there any other slides, or do we go through the
We have still like the part about the different competing bills
Oh,
that are like in
yeah,
Congress
I
right
think-
now.
Right.
I think that's
So-
important.
Here PNHP made it very concrete, saying that sound-alikes can be dangerous. So of course now we're just talking about like competing health care legislation, but there are different plans, and not all of them are like single-payer Medicare for all, but some of them have similar names like Medicare for America or Medicare Extra for all, Medicare Advantage for all. At the same time, it is not the guaranteed health care for everyone, every US resident, with no co-payments and deductibles like the actual Medicare for all single payer bill will provide. But there's always some kind of drawback that, say, there are out-of-pocket costs, or private insurance remains in place, making things more complicated. So that's an important
Yeah.
issue right now.
And I think the Medicare name, it's in a way unfortunate that that's the name, because Medicare is not now what it was.
Right.
And I suspect it has something to do with stigma attached to it. But I'm thinking that what we're looking for is more like Medicaid for all, in terms of what the insurance looks like. Is that
Well,
so
that
or not?
Depends on the state. In
Oh.
some states, Medicaid is excellent, and in others, it isn't. So it depends on where you are. But I get your point, because Medicaid generally covers more than Medicare does. It
Yeah.
will include dental in a lot of places, and vision, and I don't know what else. Vermont has a good Medicaid program, I happen to know.
Now,
But some states have
Yeah.
really terrible programs, so.
Now, what would the transition look like to a program like this from what we have? I mean, how,
I think now both the House bill and the Senate bill have 2-year transition periods.
I think so, yes.
Yeah. So basically, the 2-year transition is to permit not only people to have time to change their enrollment, but also the systems which have grown up, systems which are being used by providers and by employers and so forth. Their whole computer systems have come into existence to service the financial industry that is managing insurance. And there will be no need for those systems, so they have to retool. And that's basically what the 2-year period is for. And the other purpose of the 2-year period is to provide the rank and file workers who are just, doing their job and pushing the papers, whether they're billing specialists, whether they're working in insurance company offices or things like that. They're going to need new jobs. And so both the Senate bill, that's S1804, and the House bill, HR 1384, both bills have provisions for funds to provide severance pay for 2 years and training to help them be reemployed. And that is a lot better than has been done for almost any other industry where there has been a change. And it certainly is better than employers have done for their employees when they
Sure.
decided they have to go lean and say, sorry, you don't have a job.
now, if we end up waiting for national action, is there anything that can be done on the state level to help cover more people in Connecticut and create a better system here? Could we do some kind of Husky for all?
I've been thinking that we could.
Are there particular obstacles to it? I'm thinking that, Connecticut has sort of been hemorrhaging, residents for quite a while, the last couple of decades. And one way to help get businesses and people to stay here
Right.
would be if we provided better health insurance than other states in the region.
Yeah.
The state that passes statewide, universal, single-payer, publicly funded, comprehensive health care will become a mecca
Yes.
for jobs.
Yeah, and it could be Connecticut.
Yes, it certainly could.
Yeah.
And contrary to popular belief, we've got plenty of money in this state to fund it. The thing is that it's staying in private bank accounts because we're not taxing people with high incomes.
That's true, and that is something that's coming up this session, I hope. I know our governor is not in favor. I totally
course he's
don't
not.
understand.
I do.
I do understand, but I don't, because
Right.
once a person has, once you're earning more than $2 or $3 or $10 million a year, do you really notice if you're, 10 million and plus, the $100 you earn past 10 million, most of it gets, sent, as taxes to the government? I mean, does that really cause privation? I don't know. It just seems odd to me. I can't even imagine what I would spend that kind of income on. And I think it's sort of a mistake to call it a millionaire's tax, because I know my son lives in Greenwich, and anyone who owns a house has $1 million in assets.
Right.
However, a lot of those people aren't earning more than a couple $1 million annually, and I'm guessing that even in Greenwich, if you're earning more than $2 or $3 million annually, you can afford to pay
Especially
taxes on that
if you're not
highest
paying for health care.
bracket. That's true.
I'm just saying.
And there are other states, though, that are proposing, our northern neighbors, Massachusetts, or western neighbors, New York State, they do have state-level single-payer bills already in their respective
And we
legislative
don't,
chambers.
do we?
I
We don't.
do not
I
know
don't
of
think so.
Connecticut
Not yet, not yet.
having legislation, but actually it's also having a lot of support, say like in New York State, the state-level single-payer bill that they have, the New York Health Act, it already has passed the New York State Assembly 4 years in a row. So they did already pass it in one of the two chambers, and now they're working, of course, on the New York State Senate and the governor's mentioned, and of course also we have Massachusetts with their single-payer bill that I think now the state Senate is already at 41 co-sponsors, and there's a lot of grassroots activism. There are a lot of local groups who are just reaching out and contacting the legislators, or hosting events. Like recently we have seen a lot of Medicare for All single-payer events, like here in Connecticut, but also in other states. So there's a lot going on, a lot of a positive trajectory.
Well, that's good to hear. I think one of the challenges has often been that people have an irrational fear of socialism, or what's considered socialism. And that, I think most people are relaxing a little bit more on that.
I think so, especially younger people.
Yeah, and maybe there is more of a
Yeah,
realization that a lot of what we do is socialized.
Definitely.
The public good. We all love our public libraries and our public schools and our getting our roads plowed and our trash picked up. So I think that fear of socialism, and there is a group that still has that fear, but I think it's sort of dissipating slowly. What you're talking about in terms of what's happening in Massachusetts and New York is hopeful, but it doesn't make it likely that Connecticut will be the mecca that everyone comes to.
Well, we could be.
It's up to us. We can still get active ourselves too.
So what other opportunities do you see for us to take some action on this? What can people do to help move it along?
Well, there are some very concrete things. First of all, find out what is the position of your representative in Congress. For folks who are living in the 5th District, their representative, Johanna Hayes, has already co-sponsored H.R. 1384, but she could do more, and it makes sense to call her office and ask her to do more, because if they don't hear from us, they'll think it's not important. You can bet your shoes that they will hear from the folks who have a vested interest in keeping us indentured to their industry. So we need to speak up. And so if you live in the 5th District, call Johanna Hayes. She has an office in Waterbury, and tell her, thank you so much for co-sponsoring H.R. 1384. Thank you for taking that leadership position amongst all the representatives in this state. And would you please also join the Medicare for All caucus in the House, because each step that you take to ratify the idea that every person in the United States deserves to have health care, that makes the chances of the bill stronger that it can pass. It might be good to remind her, Congresswoman Hayes, you are on the Labor and the Education and Labor Committee, and that is one of the committees that H.R. 1384 must pass through. Please protect and guard the bill as it's passing through your committee so that it comes out as it came in, strong and robust for the people. And then at whatever time it comes to the floor, please vote for that bill. We have to be very concrete and specific in our asks. If you are a member of the 1st District, your congressperson is John Larson. He has not co-sponsored 1384, so the first ask is, would you please co-sponsor 1384? His aides may tell you, well, I have Congressman Larson has a better idea. It's the so-called Medicare Buy-in and Healthcare Stabilization Act of 2019. Okay, and Congressman Larson is co-sponsoring that. So is Congressman Courtney in the 2nd District, and they think that's a better bill. They'll try to sell you on it. Please don't. We have a large and complete head-to-head comparison between the Buy-in Act and the true Medicare for All. I hope you'll post it on your website so people can look at it. But basically, it does not change the care that is available. You still have to buy co-insurance, you still have to pay premiums, all of that song and dance, all of the extra expenses that employers, providers, and people have to pay to support the industry continues. The only difference is that if you're 50, you get to buy into the existing Medicare system. And they actually opened the door wider for privatization of Medicare, so it's going in the wrong direction.
Now, are there any more slides? We only have about 3 more minutes. So if we go through, if there are...
So yeah, once again, this is just the overview. We have 106 co-sponsors of the Medicare for All Act, for example, in the US House. Yeah, once again, we do have 5th District, John Hayes, but we do not have
Joe Courtney or
2nd District or other Connecticut US reps, so they could gladly sign on. And yes, please give them a call. At the same time, also feel free to follow Medicare for All Connecticut on Twitter or like our Facebook page, and join us for any future activities and events.
Okay, and there, thank you. Okay, we have about 2 minutes while I get this laptop repurposed. And I just wanted to make one point with you. When you mentioned everyone being covered, one thing that's always seemed very bizarre to me in this country is that what kind of health coverage you have depends on where you work, what your job is, what your marital status is, just weird family related. It's like people are not individuals at all. Everyone's in a little subgroup, and that subgroup just determines like what kind of health care you're eligible for, and it just seems very strange to me.
It is very strange.
So who would have thought? Yeah, I know. I have a gay cousin that she and her partner, before they could get married, she would write articles on, well, why is my family not treated like, my cousin's family? But the bigger point is, why aren't we all just people?
Yeah.
And get, the possibility for coverage just because we're people and we live here.
Right.
So I guess we're all set? Okay, I guess we are out of time. Thank you so much.
Thank you for having us.
People can, if they want, go and find out more about Medicare for All, and we'll keep folks posted what presentations you might have around the state.
Thank you.
So thank you for coming
Thank
on
you.
and talking
for
about
having
this.
us.
Hopefully there are some exciting things in the works, if not this year, then not too far off. So thanks very much,
Thank you.
and we'll
Thank
see you
you.
next week.
Thank you.
Okay.
Thank you.
Tuimbe Afrika, tuimbe Afrika, tuimbe Afrika, ni mpenda mzuri sana. Tuimbe Afrika, tuimbe Afrika, tuimbe Afrika, ninakupenda sana. Tuimbe Afrika, tuimbe Afrika, tuimbe Afrika, ni mpenda mzuri sana. Tuimbe Afrika, tuimbe Afrika. Oh, tuimbe